So we're going to talk about prevention and treatment of perioperative DVT and PE, or venous thromboembolism. Same disclosures, we have some stock in our family. We'll talk about the epidemiology of these venous thromboembolic events. We'll talk about assessing VTE and bleeding risks. We'll talk about the pharmacology of the drugs that are used to treat this. There are guidelines from the ACCP, which we're going to go over. Those are the most recent ones. I think that they'll probably be updated again, and they're trying to get enough data related to the DOACs to provide good guidelines. We'll talk about some controversies in the prophylaxis arena, and then we will talk about the treatment for postoperative VTE, and there are some relatively recent guidelines for this that I'll update you on. Some just background, everyone knows, I think the incidence of venous thromboembolism does vary widely. It's dependent upon the type of patient, are they inpatients or outpatients, and the type of illness that they have and the surgery they have. They're both patient and surgical risk factors. We do know that prophylactic regimens are out there. There are many, we'll go over them, and that they work, and that these regimens also have potential to cause some harm, particularly bleeding and trauma to the skin and reduction of blood flow. And like all hemostatic issues, and we've talked about this through the course, is that here the issue is always trying to balance bleeding and thrombotic risks. We're trying to figure out, are we better off with more or less coagulation? Would the patient be more at risk for thrombosis or more at risk for bleeding? And we want to understand how to do this from the patient's perspective as opposed to the perspective of the type of practice that I have as a clinician. And here again, I'll just a list of the risk factors that you're all quite familiar with, the usual suspects. I'll just point out to you that really anytime someone's in an inflammatory state, those who have autoimmune disease, critical illness, respiratory failure from pneumonia, for example, those inflammatory states are part of what increases the risk because inflammation does turn on the hemostatic system. And then there are a series of surgical risk factors. Again, these are the usual suspects everyone knows about. Certain types of surgery are higher risk than others. We know that ortho surgery, spine surgery, higher risk than neurologic and spine vascular procedures and so on. But all patients who are having surgery do have some increase in risk. And the length of the procedure, GA, and having catheters in place makes a difference. Now you can take these risk factors and you can quantify risk numerically. And there are a number of scoring systems that have been created. I'm showing here the Caprini score, which I think is a very useful one. There are other ones. You don't have to use this one. But I'll point out a couple of things to your attention here. You'll see that they have different types of risk factors, and they score them with points. I'll show you just being over 75 years of age is a high risk factor. You get 3 points for that, as much as having a previous venous thromboembolism, which certainly is a risk factor, or having a thrombophilic state. So the other thing is the highest risk goes to those patients who've had a previous stroke. They're immobilized, those who are having hip or knee surgery, those who've had injury to their hip, their pelvis. Again, you don't have an extremity that's moving and there's been injury to that area, and those who have a spinal cord injury. So you get 5 points for those things and 3 for the other, and you can see the other types of things that also confer risk, and you can get points for each of those. And then you're supposed to add these things up, and as you add them up, it increases your risk. And so what you're seeing here is the Caprini score in that second column, then very low, low, moderate, and high risk. And as you can see, as the Caprini score increases, your risk for having a symptomatic venous thromboembolism, a DVT or PE, goes up. And the same thing is true for asymptomatic VTE. Now, why do I show you this? The asymptomatic part, well, asymptomatic ones can go on to be symptomatic, and you'll see that the rate for the asymptomatic ones is 10 times higher than the ones that we can overtly see. I'll also point out to you your attention that those, to be in the high risk category, you need a score of 5. Okay? And I just showed you it doesn't take much to get to a risk score of 5. There are a lot of patients who are going to get to a risk score of 5, and in fact, most of these scoring systems don't get into the super high risk category, right? Someone who had a thrombophilic state, had a previous VTE, is over 75 and coming for knee surgery. You do have these patients, and yet everyone's kind of get bucketed into this high thrombotic risk category. Of course, there are risks associated with these agents, and for therapies, there are bleeding risks. And we want to be able to quantify those. I mean, what do we mean by bleeding risks? We have patients who have major bleeding. Again, how you define that? Certainly fatal bleeding, organ space bleeding, reoperation. Those are major risks. Many would put in transfusion greater than 2 units or equal to 2 units as a major bleeding. I'm not so sure. If we're going to compare apples to oranges, you should know that the risk of dying from getting a transfusion is fewer than 1 in 10,000. The risk of dying from a symptomatic VTE is 1 in 100. Okay, so they're not exactly the same thing in terms of weighing their risks. But again, these things need to all get quantified and understood. We understand minor risk certainly is different. And then these mechanical devices do have some risks too. They can cause skin breaks or ulcers and necrosis. So there's no free lunch here with any of them. Here are the regimens. Again, I think most everyone here is familiar with them. You have mechanical methods. You can use aspirin 81 or 325 twice a day, low-dose unfractionated heparin twice or 3 times a day, low molecular weight heparin at a 40 milligram once a day dose or 30 twice a day for enoxaparin, fondaparinux, warfarin guided by the INR, and then we have the 2 agents, the DOACs that we've talked about for VTE prophylaxis, rivaroxaban 10 milligrams a day or apixaban 2.5 milligrams twice a day. So a lot of regimens. A little bit about the pharmacology. I showed you this the other day. Coagulation cascade. You know that warfarin works by inhibiting the production. It prevents you from making certain coagulation factors 2, 7, 9, and 10. And if you have fewer of those factors, you can't clot as well. Then you have dabigatran, otherwise known as Pradaxa, and that is a direct thrombin inhibitor 2A. And then you have the anti-10A drug. So they inhibit the action of 10A and prevent thrombin from forming. Those are the rivaroxaban, apixaban, and edoxaban. Quick lesson about unfractionated heparin versus low molecular weight heparin. Really the major difference here is related to one of the molecules. You have this pentasaccharide piece that activates antithrombin 3 and accelerates its endogenous activity about 1,000-fold. Unfractionated heparin here, you can see has this long piece that helps it to bind thrombin, and by helping it to bind thrombin, it increases its activity against thrombin, and so the anti-2A activity is much greater than the anti-10A activity. Low molecular weight heparin, similar to unfractionated heparin, has this pentasaccharide piece, so it activates antithrombin 3, but it doesn't have a long piece. It has a much shorter other unit, and it can't bind thrombin. Therefore, the activity against thrombin is less than the activity against anti-10A. So anti-2A is more than anti-10A. That's just the difference pharmacologically for why unfractionated heparin is different from low molecular weight heparin. Both of them can work. Now, the DOACs, or NOACs, NOACs, they essentially, I showed you a graphic about similar to this with AFib. In treating patients who have venous thromboembolism, similar to the AFib literature, what they show is you get at least equivalent efficacy, and that's the up here at the top here, at least into recurrent VTE, at least equivalent efficacy, but you have fewer major bleeds for both of these agents. So they're thought to be safer and equally efficacious as warfarin or low molecular weight heparin. Does postoperative venous thromboembolic prophylaxis actually reduce the incidence of VTE? And we all know, because we do this, that the answer is yes. And these are just data showing that's the case in both general surgery and orthopedic surgery. The graphic here, the yellow bars are showing the incidence of venous thromboembolism on an absolute scale, and the blue bars are showing how much of a reduction you get compared to placebo. And what you can see is whether you're general surgery or orthopedic surgery, they work. All of the regimens work. They work to a lesser degree. Some are better than others, and we'll go through that in just a moment. The other thing I want you to notice is that even when you put on effective prophylaxis, the yellow bar doesn't go away, which means that people still do have venous thromboembolism even if you have prophylaxis on board. Now this is a table more for your reference to shows you advantages and disadvantages of different agents, which are listed on the left-hand side of this table. They have relative efficacies are shown there with the pluses. Some of them have the convenience of oral dosing. Some of them, are, of course, are sub-Q. Monitoring is required for warfarin only. Heparin-induced thrombocytopenia is a problem that is related, of course, to the heparin. Low molecular weight heparin preparations can cause this. Fondaparinux very rarely. Some of them are renally cleared, some of them are not, and so you want to keep that in mind as you might want to dose it. And then bleeding is a factor for all of these to one degree or another, except for the mechanical devices. So here I just a question I want to, as a poll, get your feedback. How many, what would you do? You have a 75-year-old woman, she's obese, she has coronary disease, she is already on low-dose daily aspirin, and she's coming for a total hip replacement. Which DVT prophylaxis regimen would you use in your practice? And forget the lettering, which is not correct. Just 1, 2, 3, 4, or 5. So aspirin only, unfractionated heparin, low molecular weight heparin, vitamin K antagonist, rivaroxaban or apixaban. Okay. So we have a spectrum of practices. It looks like the most common is answer 3. Let's go back and see. 3 would be a low molecular weight heparin, and then there are some who are using aspirin, some are using the DOACs. So the data that we have in terms of guidelines from the ACCP, they did a nice meta-analysis, and I'm going to show you those data, go through that. These are the data from the orthopedic literature on prevention of symptomatic venous thromboembolism in orthopedic surgery. What you can see in this first column, and on the left column, on the left-hand side, you see all the different regimens. So if you compare these agents to placebo, all of them work, right? Low molecular weight heparin, unfractionated heparin, vitamin K antagonists, they all have some success at reducing the number of events that are going to occur. If you compare then to placebo extending treatment, so now from 14 days out to 35 days, low molecular weight heparin is effective, aspirin is effective, fondaparinux and rivaroxaban are effective. And then in this last column, what you can see is the comparison of the agents versus low molecular weight heparin. And compared to low molecular weight heparin, low-dose unfractionated heparin is less effective, the vitamin K antagonists are less effective, and the aspirin is less effective. Okay? There are more events that you would see with each of these agents in the 0 to 14 days compared to low molecular weight heparin. And then the DOACs, you would see fewer events, and these are out to 35 days. You would see fewer events compared to low molecular weight heparin based upon the meta-analysis that these authors did some number of years ago. How about bleeding complications? Well, low molecular weight heparin compared to unfractionated heparin, the vitamin K antagonist or aspirin, no difference, no statistical difference in fatal bleeding, and no statistical difference in major bleeding when we define that as 2 or more units of packed red blood cells. In fact, there's a trend towards fewer adverse events with low molecular weight heparin. And then for DOACs compared to low molecular weight heparin, similarly, no difference in fatal bleeding, no difference in major bleeding. Now, more recently, a network meta-analysis was done which compared the different agents. Here, the standard is low molecular weight heparin. This is a low dose, meaning 40 milligrams once a day of enoxaparin. And so if you compared the low molecular weight heparin high dose, which is 30 twice a day, it was more efficacious in that there were fewer symptomatic VTEs. However, there is more bleeding. If you look at the DOACs, there is fewer symptomatic DVT and no statistical difference in major hemorrhage. If you look at unfractionated heparin, you have a strong trend, although not significant, towards symptomatic DVT, and you have more hemorrhage. Fondaparinux, again a strong trend towards more symptomatic DVT, here more, and a significant difference in terms of more major hemorrhage. And then aspirin, no statistical differences here, but you have trends towards a more symptomatic VTE, and no difference in bleeding. And this is one of the things I think that isn't always talked about, is the amount of data on aspirin is far fewer. I mean, you don't see statistical differences because there are many fewer trials. That doesn't mean there isn't a difference. It's just that you don't see statistical differences. So what guidelines do they give from the ACCP? Prophylaxis with any regimen is acceptable and preferred to no prophylaxis. Low molecular weight heparin is preferred to all other regimens and by their guidelines. They recommend that you dose low molecular weight heparin more than 12 hours before or after surgery rather than closer to surgery. Pharmacological treatment plus the intermittent pneumatic compression devices are preferred to mechanical prophylaxis alone. And then extended prophylaxis is preferred to short-term prophylaxis. And then what they say is for those patients who are at increased risk of bleeding, and that's a little nebulous, what is increased risk of bleeding? They do say IPCs, so the mechanical devices are preferred to pharmacologic agents. And again, this is just one group that provides recommendations. If you don't like these recommendations, you can use the Orthopedic Society recommendations, and they're different from these, where I think that they are noting more concern about risk of bleeding, and they're more reticent to use pharmacologic prophylaxis. I gave you this article, which was published just several months ago. And I know that there's concern about bleeding out there in the community in these orthopedic patients, and I think this article kind of addressed that. So there was a large randomized clinical trial that looked at the use of DOACs followed by aspirin in patients undergoing total hip replacement or total knee replacement surgery. Okay, so it was over almost 3,000, actually over 3,000 patients in the study, almost split half and half between knees and hips. Okay, and if you look at this population, on average they're 62 years old, about half of them are male, the BMI is about 30. None of them have almost none of them have cancer, and really none of them have had a previous thromboembolism. So I think this is kind of your run-of-the-mill patient. This is not a real high-risk patient. This is kind of your average guy who comes in there for a hip or a knee. So moderate risk. So what they did is they took these patients and they gave them all rivaroxaban, 10 milligrams a day for 5 days immediately following surgery, and then they either got aspirin, 81 milligrams a day, or they continued with rivaroxaban, and they continued for 9 days in knees and 30 days for hips. And what they show here in that table is that there were no difference in any outcome between the groups who got aspirin after rivaroxaban or just got rivaroxaban. Okay, so there was no difference in VTE, no difference in PE, no difference in major bleeding. So I think for those who are concerned about bleeding, this may be one regimen that makes sense in that, you know, during the most high-risk period, which is those first several days after surgery, you're using more intense therapy, and then you de-escalate to aspirin afterwards. Now, how about general surgery? Well, again, in this meta-analysis that was done by the ACCP, for symptomatic VTE, they looked at the relationship between which was better, low molecular weight heparin or unfractionated heparin. And here, low molecular weight heparin did have fewer VTE than unfractionated heparin, and mechanical prophylaxis was less effective. Not surprisingly, we're all aware of that. Now, I give you a Cochrane database review, and what they did in this review is they compared the combination of prophylaxis, mechanical prophylaxis, and pharmacological prophylaxis compared to mechanical alone. And in this meta-analysis done by Cochrane, there was more efficacy by combining the two together, 65% risk reduction in venous thromboembolism by combining them versus mechanical alone. And of course, bleeding complications here, low molecular weight heparin actually had not significantly different, but was fewer numerically different than unfractionated heparin. And mechanical prophylaxis, as you imagine, would of course have fewer bleeding events than pharmacological prophylaxis. And so what recommendations do they come from the ACCP? You have the risk category for thrombosis there on the left, and then you have split into two categories, what's called average bleeding risk, which are saying 1%, and high bleeding risk, which are saying 2%. Again, I'm not sure exactly where those definitions come from or what 2% of what exactly is meaning. But let's just talk about the average risk for a moment. What you can see here, as the risk goes up, the intensity and the duration of the prophylaxis increases. And so anyone who's more than very low risk should get something, and then as you get into the high risk, they're recommending at least some type of pharmacological prophylaxis, potentially in combination with mechanical devices. Now, for those who are having risk for HIT, you can't use a heparin, and they're advocating aspirin or potentially a DOAC. You have to recall, and when these recommendations came out now several years ago, there hadn't been much use of DOACs. So I think the next recommendations are going to come out with the DOACs. And then for the high risk, and I'll point out to you here, they're saying 2% or more. I'm not sure why the 2% versus a high risk for cancer, in cancer surgery, for example, or we're talking about the 6% risk of VTE when we know that those VTEs are more likely to lead to death than the bleeding complications. Nonetheless, in those who are high risk, they do advocate for just using the mechanical devices and adding to the mechanical